Great. Well, some wonderful talks from Dr. Hunt and Dr. Kathari really set the stage here. Very grateful that I follow them in this session, and really I want to thank the course directors for inviting me and putting this together. Um, so just to move along, I'm tasked with speaking to you all about managing stones in the context of chronic pancreatitis. These are my disclosures. Our learning objectives for this talk are for us to understand the role of endoscopic therapy in the multidiscipline management of symptomatic chronic pancreatitis. Well, we've already had some discussion of this, but specifically recognize the therapeutic options for patients with symptomatic obstructing pancreatic duct stones, and recognize the risk benefits and limitations of existing therapies for symptomatic pancreatic duct stones. Let's talk just briefly about symptomatic chronic pancreatitis. So this is really a very challenging disease. This is data from a publication that looked at a national readmission database, and specifically looked at patients with chronic pancreatitis and what factors predicted readmission. So certainly out of symptoms, abdominal pain was one of the biggest predictors for readmission in patients with chronic pancreatitis. Very common symptom that we see patients for with chronic pancreatitis, probably the most vexing symptom for patients with chronic pancreatitis, and the symptom that's most likely to bring them back to the hospital over and over again. And this study did find, though, that patients who had had interventions, ERCP or pancreatic surgery, were maybe a bit less likely to be readmitted to the hospital. So this, with some other data, suggests that in certain populations and carefully selected patients, there is the opportunity where we can help these folks with intervention and maybe decrease the overall cost burden of their care. And maybe assist in changing the trajectory of the natural history of their disease. So what's so challenging about managing patients with chronic pancreatitis? Well, there's many challenges. Many would argue that these are challenges in terms of their clinical care, but also studying therapies in these patients. So first of all, we know from a number of publications that there can be a very poor correlation between imaging findings and symptoms. What do I mean by this? You can have a patient with a CT scan that shows dense calcifications, the dilated pancreatic duct and obstructed pancreatic duct, and they have no abdominal pain. And then you can have patients who have small duct disease, very minimal changes of chronic pancreatitis, have a good story in terms of their symptoms and risk factors, and have excruciating, debilitating abdominal pain. And what we've learned from emerging research is that really there's a lot of other factors, a lot of other dimensions to this disease that impact our most important metric in terms of measuring how well these patients respond to our therapies, managing abdominal pain. And these include how our patients process pain, their coping behaviors, is there comorbid anxiety, depression, how long have they had pain? And these other factors will a lot of times and can disproportionately impact patient reported outcomes. The other challenge that we have is existing data on endoscopic management of chronic pancreatitis spans 20, 30 years. Very recently, we're really getting into some high quality studies utilizing randomized control methods to study these therapies. But the existing literature, the foundation literature that we have, is mostly retrospective, has significant heterogeneity in terms of its study designs and in terms of metrics that they utilize to study outcomes in these patients, and the types of patient reported outcome measures that they will use in these studies. And then, as any endoscopic therapy, one hindrance, one challenge is that there's a very high placebo response rate. And that's something that we really have to overcome, or at least think about whenever we design any studies or study any kind of therapy for chronic pancreatitis. So, how do we select patients for therapies? Well, one suggested pathway, or one thing that I think we all think about, is what is their pain pattern. But beyond that, we also want to look at what their biophysical and psychosocial impairments are. Caring for patients with chronic pancreatitis is really, I can't emphasize enough, multidiscipline management. I don't mean just interventions, surgery, endoscopy, working together as folks in appropriate selected patients, how best to decompress a patient, but we want to address kind of the entire patient. and make sure that you have a good team or at least good resources for you to manage comorbid depression. If there's any anxiety, nutrition deficits, you really need to address that as well. When we're thinking about therapies for patients with chronic pancreatitis, you want to think about what their pain pattern is. And we know that patients with an intermittent pain pattern are most likely to respond to therapies, or more likely to respond to therapies for chronic pancreatitis. Patients with long-standing pain on long-standing opioid pain medication for chronic pain and have daily severe pain are less likely to respond to an intervention in spite of what their pancreas duct looks like or what sort of complications of chronic pancreatitis you discover. So that's something that's a very important consideration whenever you're selecting patients for therapy for chronic pancreatitis. So you have a patient with maybe an appropriate pain pattern. You think they're a good candidate for endotherapy. As Dr. Kathari reviewed, we really want to make sure we have high quality imaging, and patients with pancreatic dilated pancreatic duct and some sort of obstructive pathology or complication of chronic pancreatitis are probably best candidates for selecting a therapy, or going to be responding, most likely to respond to a therapy. And so, what are our options for managing complications of chronic pancreatitis, pancreas duct complications of chronic pancreatitis? So, Dr. Kathari already talked about the approach to strictures, such as dilating and stenting. So, we're going to focus on obstructing pancreatic duct stones. So when we talk about endotherapy, what are some of the standard ERCP techniques for managing pancreatic duct stones? Well, you need to make a pancreatic sphincterotomy. You have to improve the outlet for delivering stones. If there's a downstream stricture, Dr. Kathari already touched on stenting to address the stricture in the outlet. There's different early ways to fragment stones, which include trying to grab the stone with rat tooth forceps, use a stone retrieval basket. Anybody who's ever tried to retrieve these pancreatic duct stones with a balloon alone can attest to how many balloons you'll go through. These stones have very sharp edges to them. They'll basically pop balloons readily, so it's very challenging. You can use saline irrigation, especially for stones greater than 5 to 6 millimeters. It can be challenging to utilize a basket or even a lithotripsy. Even the duct may be dilated upstream, but our baskets are designed to be used in the bile duct and not necessarily designed for use in the pancreas duct. So it's hard to open these baskets, and there's a very significant risk of impacting the basket. And anybody who has ever had that kind of experience, had to break out the Sohendra lithotripsy, it's a miserable undertaking. So for management of pancreatic duct stones, there's really more advanced lithotripsy techniques, and that's what we're going to focus on. Stones that obstructing symptomatic pancreatic duct stones that you want to think about those therapies up front are really anything, stones that I would characterize as complex, any stones greater than 5 to 6 millimeters, any stones that are upstream from a pancreatic duct stricture, and certainly stones that are in an inconvenient location, such as periampullary, or are further upstream, such as the genu or body. We're not going to talk about stones in the tail because that's really probably not appropriate for endotherapy. And there's two what I would characterize as non-traditional, non-conventional, or they're now conventional, but non-mechanical lithotripsy techniques, which is extracorporeal shockwave lithotripsy, which we'll refer to as ESWL, and single operator pancreatoscopy with intraductal lithotripsy, which we'll refer to as SOPL. So what is ESWL? So it's essentially a technique that has been repurposed or extrapolated from our urology colleagues. We're essentially using an external lithotripter to fragment stones, and then later, most often following with an ERCP to extract the stones. So how do we prepare patients for this procedure? Well, you need pre-procedure cross-sectional imaging. Most often we perform a KUB to confirm that the target is radio opaque. Because we have a imaging system associated with this, usually fluoroscopy. We got to be able to see the stone to target it. Some stones are radiolucent on KUB, in which case pre-procedure ERCP can assist, and you can place a stent right up against the stone, essentially serving as an arrow to point to our target. And then usually we perform these procedures under general anesthesia or epidural anesthesia. These patients need to hold very still so we can target the stone and perform the lithotripsy procedure. Every lithotripter has basically 4 components to it. There's the generator. More modern lithotripters usually use an electromagnetic generator, and I think most centers that are doing high volume cases now have electromagnetic generators to generate the energy. And then there's a focusing system to converge the energy on the stone. an aqueous coupling medium to transmit the energy from the lithotripter to the patient's body and into the tissues, and then an imaging system, ideally fluoroscopy, to target the stone. And shocks are usually delivered over 90 waves per minute. On average, it takes about 2 to 3 sessions to get fragmentation. So how effective is Eswol for managing pancreas duct stones? There was a recent meta-analysis of 22 studies, almost 4,000 patients. Technical success was was substantial with this, with almost 70% successful clearance of pancreatic duct stones. Improvement of absence of pain in these patients was reported as high as 64% across these published studies. There's still a lot of gray areas within Eswol for managing symptoms of chronic pancreatitis, specifically pancreas deficiency in the form of exocrine and endocrine deficiency. Most of the studies that even have metrics along these lines are heterogeneous, and it can be very difficult to at this time. It's very difficult to ascertain how helpful Eswol is for managing pancreas deficiency symptoms. And then certainly there's a lot of heterogeneity in terms of quality of life metrics across these studies that report outcomes for Eswol. So what are some predictors for technical success, or some ways that you can maybe predict if a patient's going to respond to Eswol? Well, stone morphology is important. Smaller stones, lower density, solitary stones are more likely to respond to Eswol. Locations in the head are more likely to respond. If there's an absence of a pancreas duct stricture, it makes things easier. And then really centers that have expertise are more likely to be successful, which makes sense. Centers that are higher volume, and when Eswol is performed at these centers by gastroenterologists, they tend to have a higher comfort level with not only preparing the patient, performing these procedures, but also have a higher threshold in terms of the number of shocks that they'll deliver to fragment these stones. At our center, Dr. Watkins, we concentrated the expertise in his hands. He has a long legacy of experience with managing these patients. And so certainly we're grateful for his help here at IU. Pancreas duct stent placement is an important factor, and then we utilize IV secretin as well to stimulate pancreas secretion and also create a liquid media within the pancreas duct and maybe a flushing mechanism for the stone fragments during the case. I have a list here of complications of Eswol, which you can see the complication rate is low. Pancreatitis is a common complication of Eswol, especially when we pair this with ERCP, same session. There's other listed complications. There's rare severe complications related to tissue trauma, but there's case report levels of these, and usually these severe, devastating complications, the rate is less than 1% for these procedures. So what are some other options for lithotripsy? Well, we can perform intraductal lithotripsy. So SOPL, which I referred to briefly before, is an ERCP technique where we gain access to the pancreatic duct. We use a digital single operator cholangiopancreatoscope. We direct therapy at the stone under direct visualization, and you can either use laser light energy with a holmium laser, where the energy is absorbed by the stone target for fragmentation, or Eswol within an aqueous media and lavage of the pancreas duct. You can impact the lithotripter and use electrohydraulic shock waves to break apart the stone. So what is the efficacy of SOPL? So we're gaining some experience with this, but the reports are still in small to medium case series. A recent meta-analysis of 10 retrospective case series studies of 302 patients did show a high rate of technical success of over 91%, reasonable rates of clinical success, and they did stratify outcomes based on laser lithotripsy. But overall, between the two intraductal lithotripsy modalities, there seemed to be a decent rate of clinical success. Single procedure success seemed to be somewhere around 50% or slightly more than that, and the rate of adverse events was about 8% across reported studies. Now, we are gaining some prospective data. Dr. Bruno was kind enough to report the results of his Pellstone study at a recent DTW session, sharing that with us. This was a prospective study of patients without prior ERCP who underwent and no prior Eswol treatments, who underwent SOPL for management of symptomatic pancreatic duct stones. There was a significant, I won't call it dropout rate, but a significant decrease in the number of patients moving forward for various reasons, challenges with getting deep cannulation, or patients whereby they were able to extract the stones after a first a session of stenting. But overall, there appeared to be decent clinical success with this technique when studied prospectively, 72%. And they looked at mean Zbicki score declines in these patients, which was substantial with this intervention. There was a very significant rate of adverse events, with over 26% of patients having been found to have posterior speed pancreatitis. I think this is important, and this is maybe a good lesson for when you track outcomes, especially adverse events in the context of prospective studies rather than retrospective studies, especially when we refer to ERCP. And so this may be, this is something for us to look at and track here. And the rate of posterior speed pancreatitis may be a bit more substantial than has been reported in retrospective case series. So that's something to think about. And some lessons from this include one important lesson that maybe Dr. Bruner imparted to us, or he learned from doing this prospective study. There's not an insignificant proportion of patients with complex stones who, even after a first round of ERCP and stenting, you can extract the stones without having to do lithotripsy. And certainly this may assist with delivering stones at subsequent sessions, even if you do lithotripsy. The other thing to think about is this higher rate of posterior speed pancreatitis, and this should maybe come into our process in terms of consent for these patients, and we should maybe very carefully discuss with them that the rate of posterior speed pancreatitis is not insignificant. This is a rate that we've seen with other studies with SOD, so this is not unsubstantial. We may want to be very careful how much we irrigate in these patients, and then certainly want to use systematic posterior speed pancreatitis prophylaxis such as NSAIDs, and consider prophylactic pancreatic duct stent placement in these patients, even if you are finishing up therapy. So what are the ESG guidelines for management of pancreatic duct stones? So they do recommend ESWAL for clearance of mean pancreatic duct stones greater than 5 millimeters. They emphasize this as the primary lithotripsy modality over SOPL, and understandably because there's much more data that backs it up. And then they recommend SOPL when ESWAL is not available or ineffective. However, there's some things to think about when we're weighing these two techniques for managing pancreatic duct stones from a lithotripsy standpoint. SOPL does offer some advantages. It allows you direct visualization of your target. It's a great way to manage radiolucent stones that cannot be targeted with ESWAL. AEs, there are rare AEs with ESWAL, but certainly you don't have any risk to adjacent organs whenever you're performing SOPL. Importantly, it's a matter of access. There's a handful of centers throughout the United States, I'm sure the same for Europe, that have experienced and performed this technique, whereas SOPL, theoretically, with proper training and cultivating expertise, has a much greater potential for access. So that's something to think about. So are there any comparative studies between these two modalities? We look retrospectively at our experience at IU. We performed a comparative case series analysis of our experience for managing symptomatic pancreatic duct stones greater than 5 millimeters, consecutive patients at IU between 2013 and 2019. These patients were managed with either SOPL or ESWAL. Technical success was stone fragmentation and complete clearance of the duct. These patients could cross over between the two modalities at the treatment discretion of the physicians at our center. We looked at total number of procedures. We also looked at improvement of pain with clinical follow-up, routine clinical follow-up in these patients in terms of their VAS scores or reported pain at the time of their follow-up. And then we did look briefly at EPI resolution in these patients and success in categorize that as a session of pancreatic enzyme replacement therapy, but we'll focus on technical success and pain. So baseline characteristics for these patients, as expected, the location of the stones tended to be more head and neck in patients that we managed with SOPL. The number of stones was a little bit slightly higher in the SOPL group, especially in terms of proportions of patients with three or more stones at the time of presenting for interventions. And at least within the context of this case series of our experience that we published, we tended to use SOPL more as a rescue technique and as well as the primary therapy. But looking at the main outcomes between these two groups in terms of technical success, it was similar between ESWAL and SOPL. We did a multivariate analysis to look for any negative predictors for technical success. We did not find any. In terms of number of procedures, total number of procedures, which included ESWAL and ERCP, it seemed that SOPL was able to achieve its endpoint, its goal, with a fewer number of procedures. Predictors for this included SOPL over ESWAL in terms of fewer procedures for technical success and smaller stones. In terms of pain improvement, there appeared to be a similar rate of pain improvement between Eswal and Sopel for managing symptomatic pancreatic duct stones, and we found that successfully clearing stone from the main pancreatic duct predicted pain improvement in this population. In terms of adverse events, it was very similar between the two groups. I have it listed here, but I will emphasize again, this is a retrospective case series. Numbers in the Sopel group, at least at this time, are relatively small. But really, what I think this is a call to design and execution of ongoing randomized studies. We have a single center prospective study at IU. We've enrolled 19 patients. University of Colorado has taken the lead as a primary site for a multi-center prospective study looking at Eswal versus Sopel for the management of pancreatic duct stones. And I think you've enrolled at this point about 19 to 20 patients across sites. So I think we have liftoff on this, and I think that we're eagerly going to await the outcomes of these prospective studies. In terms, just to touch briefly on surgery, for management of chronic pancreatitis, there was a recent meta-analysis of the three existing randomized controls trials involving 199 patients comparing surgery versus endotherapy for symptomatic obstructing chronic pancreatitis. Surgery appears to have superiority in terms of long-term pain relief. However, there is no difference in terms of short-term pain relief, partial pain relief in the short term or the long term, and there was no difference in complications or days of hospitalization. So a little bit of takeaway points, and I do want to mention this briefly in my talk. Based on comparative studies with surgery, I think surgery, endotherapy should both be discussed with any patient who we see with symptomatic obstructing chronic pancreatitis. And then surgery may be ideal over endotherapy certainly if the patient's a good candidate for an operation. But other things to think about from that standpoint, if they desire a single intervention, one takeaway point with many of the things Dr. Kathari and I have talked about tends to take multiple interventions or multiple endoscopic procedures to resolve symptomatic or complications of chronic pancreatitis. There are many patients who are poor candidates for Eswal. They have tail predominant disease. They have an inflammatory pseudotumor in the head of the pancreas. These patients may not be good candidates for endotherapy. If they're coming or returning with recurrent symptomatic pancreatic duct obstruction, it may be time for them to transition to surgery. We talked about some of the guidelines who suggested 2 years of endotherapy. I think that's a bit long. Because of this data that we see from some of the comparative studies with surgery, you may want to think about at a shorter interval converting those patients to an operation. And then certainly patients who have multifocal compound complications of chronic pancreatitis is going to be a tall order to tackle and resolve a patient's complications if they have biliary, they have a duodenal gastric outlet obstruction, and they have a pancreas duct obstruction. I think that's asking a lot for endotherapy. So you really want to think about referring those patients to surgery. So what are some conclusions from this talk? Select patients with painful chronic pancreatitis very carefully for interventions. It's not appropriate for all. Eswal and Sopel appear to be effective options for clearance of large pancreatic duct stones, although we need more prospective data and comparative data. While Eswal, one thing we didn't talk about, there's some studies that suggest Eswal maybe can be done alone, but we tend to perform ERCP to clear the pancreatic duct after Eswal because, I think there's some data that suggests that you want to make sure that you completely clear that obstruction, that it gives you a little bit higher likelihood of resolving that patient's symptoms. ERCP, same day with Eswal we tend to do, but more importantly, Sopel approach may offer fewer procedures and shorter procedure duration in select patients with obstructing pancreatic duct stones. You should consider with Sopel, there may be a higher risk for post-ERCP pancreatitis. Whenever weighing the two lithotripsy techniques or before embarking on this therapy, I would encourage you to integrate that into your consent process with the patient. And surgery, as always, is an excellent early choice for many patients with chronic pancreatitis and should be, I think, discussed with a patient up front before embarking on endotherapy. So that's the conclusion of my talk, and we'll, I think, move on to the next speaker for the sake of time.
Thank you, Jeff.